Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan. I'm one of the instructors at Valor Medical Services, and welcome to ECG Interpretation Module 2B. Now, if you go back to what we went over in Module 1, 2A, we started going over several different cardiac rhythms and ECG tracings. Well, we're going to continue on. In 2B, we're going to go back through the core ECG criteria. We'll describe various criteria associated with the wandering atrial pacemaker, atrial flutter, atrial fibrillation, and different junctional or nodal rhythms. We'll discuss the clinical significance of each of these rhythms and also differentiate between controlled and uncontrolled atrial fibrillation and explain some of our concerns and clinical significance of each of these rhythms. Now, when we look at atrial rhythms are defined as any rhythm that basically originates within the atria but somewhere outside the SA node. 3 of these rhythms we'll be covering in this fit into that category. This variance typically presents with some type of abnormality involving the P waves. If we think about it, back to basics, the P wave is the actual firing of the SA node or the origination of the rhythm or the origination of the impulse. So, if it's originating somewhere outside the SA node, that would give us a change in the P wave on the tracing. Now, we'll talk about wandering atrial pacemaker, atrial flutter, and atrial fibrillation. First off, wandering atrial pacemaker. Now, this rhythm indicates that the point of origin of the impulse is outside of the SA node, wandering around to various locations in the atria. Some of the key criteria associated with this include P waves that will vary in size and shape and appearance between one and the next set of complexes. Some of these may be notched, some of these may be what we call biphasic, where it almost looks as if it's part way up and part way down. Now, the rhythm can be slightly irregular frequently due to the fact it's coming from different points in the atria. If you think about two packages arriving at your house from two different origins, they're going to potentially get there at slightly different times. Two flights coming from two different cities will have different flight times. So, as a result of that, the arrivals into the QRS complex will be slightly off, and that will cause slight irregularities. Now, this tracing would be an example of wandering atrial pacemaker. If we look at it closely, we can start using the same criteria we've used all along to determine what it is. Let's start out and work with this. We'll figure out how many beats do we have per minute. Well, if we start from the first hash mark on the top here, and we count 1, 2, 3, 4, 5, 6, and we say this is 6-second strip between those two hash marks, and we count back, we have 1, 2, 3, 4, 5. That would lead us to say that the rhythm is rate's about 50 beats per minute. If we go down through here, is it regular or irregular? Well, if we look at the gap, say, between the first two QRS complexes, and then this one here, that doesn't look to march out. And these here are going to be a lot further apart than, say, the ones before it right here. So clearly it's got a little bit of irregularity going on. If the gap between the R wave to R wave is different, so therefore we'll say it is irregular. Now, interesting to note, this rhythm can be somewhat regular, but in this one it's going to be irregular. Now, looking at the PR interval. Well, the PR interval seems to be pretty consistent between most of them. However, on some of them it starts to vary a little bit. And definitely on this complex here, we notice that PR interval is much different than a very short PR interval here, or a little bit of a longer PR interval if we come back to here. So the PR interval is not consistent, so we'll say it varies point to point. How about the QRS width? Is it wide or is it narrow? Well, if we look at it, all of the QRS complexes on here are less than 3 little boxes or 0.12 seconds. Generally, it looks to be about 0.08 on most of them, so therefore we'd say it is less than 0.12 overall. Now, the last criteria we'll look at, and it gets very interesting here, is our P to QRS ratio. Do we have a P wave for every QRS and a QRS for every P wave? Well, for the most part we do. This one here looks like it might not have much of a P wave. However, it may have something trying to start in up there. But all the other ones match up between the P's and the QRS's and the QRS and the P's. Most of the P waves are upright. However, if we look here, the one over here under this is slightly notched. This one is a little bit more rounded. This one over here is kind of peaked. So that would lead me to say that they do vary significantly in appearance. Given the varying appearance of the P waves, combined with the slightly irregular rate, that would lead us to call this sinus rhythm with a wandering atrial pacemaker. Now, this is not going to have any real significant clinical concerns just because it's wandering atrial pacemaker. The one clinical concern we may find ourselves worried about is the fact that the underlying rate, is 50 beats a minute. If the 50 beats a minute is not perfusing well, or the patient is hypotensive, or showing signs of poor mental status, that would be more of a concern, the fact that the rate is 50 beats a minute, than it would be just the wandering atrial pacemaker itself. Now, this may also vary significantly with activity. So while the patient may have a 50 beat per minute rate now, if they move from their seated position over onto the stretcher, we may see it come up. As we talked about in Module 2A, sinus brady at 50 may or may not be a problem. If they're perfusing well and the mental status is good, no chest pain, no signs of pulmonary edema or heart failure, that could be perfectly normal. The same would fold true with this. The big difference is we do note the wandering atrial pacemaker. Alrighty, now on to the next rhythm. Let's get into atrial flutter. Now, atrial flutter is a rhythm in which the atrial impulses occur at a rate that is much more rapid than the ventricles are able to keep up with. These atrial impulses actually became known as F waves or flutter waves. These flutter waves have a very distinct sawtooth or picket fence type appearance, and when we see atrial flutter, we know that many of the flutter waves will be blocked at the AV junction, which will actually limit the amount that will produce a QRS complex. If we think about a normal rhythm, we normally will see the impulses through the atria all get carried forward to the ventricles. However, here, some of these will be blocked, these flutter waves, and not produce a QRS complex. They'll just be standalone flutter waves. If the atrial rate causes the ventricles to run over 100 times a minute, it would be called uncontrolled atrial flutter. However, if the atrial rate does not cause the ventricles to run over 100 times a minute, it would be called controlled atrial flutter. But before we worry too much about that, let's look at what atrial flutter looks like. Now, atrial flutter, as we look at it, we have a very steady baseline, which is full of what we would call those flutter waves. Now, as we look at this tracing, the first thing that will jump out at us is the flutter waves. But let's go through our back to basics, figuring out what the rhythm is. First off, what's the rate? Well, this one's going to be a little bit interesting because as we count it off, we'll start from right about here, and we'll count across 1, 2, 3, 4, 5, 6 seconds, and we count back 1, 2, 3, 4, 5, 6 QRSs. So we could say it's about 60 beats per minute. However, if we were to count it differently, and let's say count from here, and we count 1, 2, 3, 4, 5, 6 seconds out to this point, we count back, we have 1, 2, 3, 4, 5, 6, 7. It's very irregular, so therefore we may have a little bit of trouble coming up with a solid rate. We'll say probably about 75 or so beats per minute. That seems to be pretty close to what's coming up. If we look at the printout, it's saying 80, but again, if you look previously, it was saying 54 right here, and here it's saying 80. This is a great indicator for providers that a rate is clearly irregular. Now, we'll notice where it's irregular, say between this set of QRSs and this one here, and these are a lot closer than, say, these out here, but when you see a significant variance, not just 1 or 2 beats, but a variance here of 20 plus beats per minute, it clearly would show we've got an irregular rhythm underlying, and it's about 75, maybe 80 beats a minute. Okay, definitely irregular. Now, most times when you see a flutter, it will be fairly irregular. And that's depending on how many of these flutter waves actually get carried through to the ventricles and cause a QRS complex that we would see here. So from that standpoint, the irregularity of it leads us to believe that it's an atrial rhythm, either AFib or A-flutter. We'll call it A-flutter based on what we see on the baseline. But let's keep going. Can we come up with a solid PR interval? Well, not really, because we look at what the PR interval is here, is very narrow. On the other side of the coin, there's no QRS for a bunch of what these flutter waves or P waves, or they're called. So we'll say there's actually no real P waves to it. There's just this fluttering going on at baseline. The QRS width, what does it tell us? Well, it appears to be nice and narrow like the average QRS. Appears to be about 2 boxes here, or 0.08 seconds, which would be less than 0.12. Lastly, we'll look at our P to QRS ratio. Unfortunately, well, there's no real P waves to speak of, so we don't have that. We just have our flutter waves or our F waves, so we would call the rhythm atrial flutter. We have the flutter waves that are going on in the atria. Depending on how well they're conducted through, some get through, many get blocked. Overall, this would be called atrial flutter. To go one step further in its nomenclature, we would call it atrial flutter with a variable conduction. The variable conduction part signifies that the amount of F waves or flutter waves per QRS varies from complex to complex. If it was consistently and there were always, say, 2 or 3, we could say it had a 3-to-1 ratio or a 3-to-1 conduction. But with it varying so significantly, we just call it atrial flutter or atrial flutter with variable conduction. Now, to move on to atrial flutter's cousin, that would be atrial fibrillation. Now, in this rhythm, instead of having our flutter waves, the patient's atria has begun to fibrillate or quiver, and it may be quivering at a very, very high rate. Thus, with the quivering, there's no P waves on the strip or no organized atrial activity, just chaotic wavering baseline. Some of the impulses are conducted through and cause the ventricles to contract, very similar to the way they do in atrial flutter. But atrial fibrillation, again, instead of having our nice flutter waves or sawtooth waves, we'll see fibrillation waves. The frequency of impulses being conducted through will determine the actual ventricular rate or the patient's pulse rate. When we're dealing with up to 100 beats a minute, it would be either controlled AFib or just plain atrial fibrillation. If we have ventricular beats over 100 beats per minute, it could be considered uncontrolled atrial fibrillation or atrial fibrillation with a rapid ventricular response. Now, when we're talking about atrial fibrillation and the atria is quivering so rapidly, the atria does very little to actually help the ventricles preload. It does very little to determine what we're going to have as far as a pulse rate. The patient's pulse rate on this will be based solely on the ventricular rate. So now let's pull up a tracing. Here's a tracing that would be considered atrial fibrillation. As always, we need to start off back to basics. Let's count the beats. We look from here, we'll start at this point, and we'll count out 1, 2, 3, 4, 5, 6. Tap it here, and we'll count back. 1, 2, 3, 4, 5, 6, 7. So in that series, we have about 70 beats a minute. Now, if we were to count a different series, let's say, for example, starting from here, and we count out 1, 2, 3, 4, 5, 6, and we count back 1, 2, 3, 4, 5, 6, 7. So it's running about 70-ish beats per minute. We come out, we say, okay, 60 to 70 beats a minute, depending where you count it. And again, showing 66 on here, so it's about 70. A lot of this will depend just on where you're counting or what segment of it you're counting. As we look to determine if it's regular or not, we look at, say, these complexes right here. They're pretty close together. These, much more far apart. These are close, these are far. It appears again to have no real regularity to it. Definitely it doesn't have any rhythm or regularity, so we will call it irregular. Much like its cousin atrial flutter, atrial fibrillation is going to have an irregular heart rate with it. Now, the underlying fibrillation here of the atria is the wavy baseline we're seeing. So when we look at a PR interval, we really can't pick out a PR interval because we have no P waves. By that same token, when we look at our QRS width, the QRSs all appear to be relatively narrow in shape. They're looking here, definitely about 0.08. Looking at this one, maybe a little bit wider. This one over here, that's about 0.08. So we'd say QRS widths could be 0.08. And when we try to come up with a P to QRS ratio, well, that's about impossible. With no P waves, we can't count that out. And when we look at the characteristics, we've got no discernible P waves and this chaotic, garbagey, wandery baseline here. That would be atrial fibrillation. Now, the fact that this atrial fibrillation is staying between 65 and 70, or 65 to 75 beats a minute or so, we definitely call it controlled AFib, or just plain old AFib. Now, the presence of either AFib or aflutter may or may not be clinically significant to the patient's presentation at all. The reason I say that, many patients live for many, many years of their lives with one or both of these rhythms or some combination thereof. These patients have diagnosed atrial fibrillation or aflutter, and they're typically on some type of medication that will control the ventricular rate. Their atria will fibrillate on and on all day and all night, but by controlling the ventricular rate, we make sure that the ventricles have time to fill. If the rate goes from controlled, i.e. under 100, up to uncontrolled, over 100 AFib or aflutter, the patient may begin showing some signs of shock. They also may begin stating that it feels like their heart is beating out of their chest or pounding out of their chest. Sometimes if a patient misses their rate control medications, they can actually have a situation where their heart rate starts to run away, and we can see atrial fibrillation or atrial flutter with a ventricular rate of 120, 140, 150. In those cases, they frequently need to have rate controlled. Okay, so when would these rhythms become clinically significant? Well, the first time these would become clinically significant is if the atrial impulses are causing the ventricles to run away or run at an increased rate that's too high. We can have a patient with an atrial rate of 200 to 300 as long as the ventricular rate's under 100 or 110 and they're not having any signs and symptoms or any hypotension or any complaint that their heart's beating out of their chest. We're not going to worry about it too much. Now, if their heart rate of the ventricles becomes 140 or 150 and it's running away, that can definitely cause problems, and therefore we may need to treat that. The second time we'd have a clinical concern is if the rhythms are new onset for the patient. And by new onset, I mean a patient states that, no, I've never had anyone tell me that I have an irregular heart rate or atrial fibrillation, never had any cardiac history or cardiac issues. These patients would be of clinical concern because with the poor emptying and filling of the atria, they can be at a high risk for blood clots. Instead of pumping all the blood out each time they pump, like we'd have in, say, normal sinus rhythm or sinus tach or sinus brady, the quivering of the atria or the fluttering of the atria may leave blood stagnant in the atrial area, and that could cause a clot to form. And if that clot gets loose, it could not only go to the brain and cause a stroke, go to the lungs, cause a pulmonary embolus, or anywhere else in the body, possibly cause a DVT in the lower extremities. So as long as the patient is not new onset AFib or new onset aflutter, and the runaway atria or the fluttering atria is not causing a ventricular disturbance, we're not really going to be too concerned about these. Like I said, many patients live years and years of their life with AFib or flutter or some combination. They're on medications for rate control and possibly anticoagulation or clot-busting drugs such as Coumadin or warfarin, things like that, Plavix. We don't worry about it too much. That's just their new norm. Now, let's move on into junctional rhythms. When we talk about the pacemakers of the heart, Remember, we used to have the SA node was our first string quarterback. Then we had our backup, which was the AV junction. Lastly, we had the Purkinje fibers. Well, junctional rhythms are originating at the AV node or junction. This indicates to us that the second string quarterback is in the game. Now, a typical junctional rhythm is usually 40 to 60 beats a minute. That's what we would expect from a normal junctional rhythm. However, sometimes we'll see junctional rhythms that are above that rate. If it's between 60 and 100 beats per minute, we would call it accelerated junctional, because it's still a junctional rhythm, but it's faster than what the junction should be doing. However, it still doesn't quite cross the line. Where it does over 100, we would have junctional tachycardia. Remember, tachycardia is a heart rate of over 100. So if we have a heart rate of 40 to 60 originating from the junction, it's just a junctional rhythm. If it's 60 to 100, it's accelerated junctional. And if it's over 100, that would be junctional tachycardia. Now, although the heart rate is different between each of them, they all begin with the same thing, which is a typically inverted or biphasic P wave, indicating that the impulse is originating below the SA node or the atria. If we think back to basics from Module 1, the upslope of the P wave is when the electricity is coming down. It would stand to reason that a downslope P wave would be electricity going backwards up the other way. Let's look at this and I'll go into it a little bit further. This would be a junctional rhythm. As we look at it closely and begin to decipher it, we'll start off with what is the rate. Well, if we count out from here, and beginning on the bottom here, we say if that's 1, we go 2, 3, 4, 5, 6 seconds trip to here. That would give us about 30 beats per minute. If we come from here, and we're going to count it again, from there, 1, 2, 3, 4, 5, 6, and we count back, we have 1, 2, 3, 4. So we're about 35 to 40 beats per minute, so that would be very low. We look at it, does it march out? Do the gaps from each one of these complexes appear pretty consistent? Well, without marching it out with a ruler, I'd say it appears pretty consistent, pretty regular. Okay. Then we'll look at the PR interval. Well, as we look in a little bit closer here, not only do we not see normally upslope P waves, we've actually got some upside down P waves. This complex here has a very obviously upside down P wave, as does the one before it. And this one over here kind of has an inverted P wave as well. That would lead us to say that the P waves are upside down or inverted, indicating that the rhythm is moving backwards, or the electricity, is moving backwards from the junction back up to the SA node. Now, when we look at the width of the PR interval, the PR intervals are all less than 0.20 seconds, so we don't have to worry about that. But it's interesting to note that we have those inverted or biphasic P waves. That tells us that it's not in the SA node. The origin is coming from somewhere below that and having to run backwards uphill. If we look at the QRS width, well, the QRS width are narrow. They're all less than 0.12 seconds, or 3 little boxes. So we now say this appears to be a junctional rhythm at about 40 beats per minute. We have our P to QRS ratio is 1:1. And so now we would say it would be a junctional rhythm. Now, this junctional rhythm could cause a problem. The biggest clinical concern we have is this rate of 40 beats a minute. Also, our other clinical concern comes in is, why is the SA node not functioning? That we come back to my favorite analogy about the SA node as our first string quarterback. He's not on the field for some reason. We don't know why or what's happened up to this point, but something's wrong that our first string quarterback is out of the game. Is it injured? Is it hurt? Do we have something more going on here? Some reason the junction, the second string, is having to take over and run the game. This can be very concerning, especially when the setting of a patient with no previous cardiac history. Although resist the urge when the patient says, "Oh, I have no heart problems," to say, "Well, you didn't until today, you do now," because this definitely indicates a problem. Is it a permanent problem? Is the sinus temporarily malfunctioning? Or is there something much more insipid? We really don't know. Now, as I mentioned earlier, the key difference between, say, a junctional rhythm and the accelerated junctional is the beats per minute, or the overall heart rate. If we look at the rhythm strip on the top, it's a junctional. It's between 40 and 60 beats per minute. If we work the one on the bottom, it would be between 60 and 100 beats per minute. So that would be accelerated junctional. They both have the same telltale inverted P waves along with a narrow QRS complex, and so therefore we'd say it's an accelerated junctional. That's our only key change between junctional to accelerated junctional. Now again, we have to remember the reason it's junctional is our SA node isn't firing, and so we need to figure out what's going on with it. Overall, the presence of any of these rhythms, junctional ones, typically indicate that the primary impulse generator, the SA node, is failing, and that the backup system is filling in. This may cause the patient to have a slower than usual atrial rhythm and also may lose much of their kick, their atrial kick. They're not going to be getting as much preloading for the ventricles, therefore, based on Starling's law of the heart, they won't be getting as much push out of the ventricles, so that can cause our pressure to decrease or diminish. These rhythms are designed to basically keep the person alive or keep the patient alive long enough to receive care and have either a pacemaker installed or whatever is bothering the SA node fixed, whether it's an electrolyte imbalance or some other type of problem that's going on. So let's close out this module and go back over the rhythms we talked about. We had our wandering atrial pacemaker, which again, the key criteria for it is slightly varying in P waves. They looked different from one complex to the next. The rate could be between 60 to 100 per minute and really had very little clinical significance, just we knew that the pacemaker was bouncing around. We had our atrial flutter, which again can be 60 to 100 and be controlled AFib or A-flutter, or uncontrolled if it's over 100. By that same token, it has those telltale F waves or flutter waves in there. Atrial fibrillation is going to typically be rather irregular. Again, this may or may not be clinically significant based on the patient's history. The big problem is, what's the ventricular rate doing? Then on the bottom we have our two junctionals. Junctional rhythm itself is between 40 and 60 beats a minute, which is the normal rate for the AV junction to fire. Accelerated junction would be anything over 60 beats a minute, but less than 100. Again, both of these will have the upright or potentially inverted or biphasic P waves. So look for the alternate P waves, and that can give us a good clue that something's coming from the junction instead of the SA node. Now, all of these rhythms overall represent a significant departure from normal in regards to how the cardiac cycle begins. While some of the rhythms may originate from different etiologies, they can all present with hemodynamic compromise if they are too fast or too slow. And remember, when evaluating a patient with AFib or A-flutter, one of the key points we need to find out is the rhythm new or something previously diagnosed that the patient may have had for years. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.